Good morning, ladies and gentlemen.
Good morning, sir.
Thank you very much. Today we'll look at this topic of examination of a patient in the clinic. Patients come into the clinic with different problems, different diseases, and this is roughly the approach you're supposed to follow as you meet these patients. On your first contact with the patient, you need to know the patient's details. This varies from institution to institution or from clinic to the clinic. Most of the major clinics, most of the major hospitals would have given the patient, the patient would have gone to register with the registry if they've never been there, where they give all the details required and they are given a card and say, oh yeah, I'm going to go outpatient clinic. Your job, the first thing which is important is a quick verification of the details on the patient's card with the actual patient. You roughly look at the details whether and verify with the patient. Are these true? Yes, yes. Then you know they are correct. This ensures no confusion at a later time when dealing with the same patient. We've seen cases of patients being seen using a wrong card. And the wrong card may even come with presenting components which are completely different. After that, please collect or ask the patient to give you what are the problems. That is why she has come to the hospital. What are the problems? The problems will be presented to you. That's why in the medicine they say you have to write presenting complaints, what the patient is complaining of, presenting it to you. It's not a present for enjoying yourself, but to hear the problem of the patient. Important points is let the patient tell you what his or her problems are. Don't chip in, let them say it themselves. Don't be suggestive to no, let her talk on her own. Immediately you start putting in such comments, older patients, scared patients, they start agreeing with you when it's not supposed to be like that. Let's find out when exactly the problems started, any aggravating factors which makes the problem worse, any relieving factors which relieves the pain or whatever problem they have. Find out any medicines they've taken to relieve their condition. Please, number 6, very, very important. Avoid suggesting possible answers to the patient. When you're asking, you yourself, you should avoid suggesting possible answers to the patient, as this may sway the patient to your ideas. Why? Especially elderly patients, my little experience in this, abaniba doctor, when it's not supposed to be like that. So let the patient say it from our own mouth. Of course, if you are not clear, you are, as a clinician, you are also entitled to have clarity of what she's talking about, but not suggesting possible answers. No, I get this and quite in malaria. No, such are not good comments to the patient. It's good for you, but the patient will say, when it's not malaria. So whatever you try to suggest, elderly patients tend to go for it. So please avoid suggesting possible answers to the patient. This sways the patient to your ideas, and you can end up missing your diagnosis. Approach to the patient, please, must always respect the patient, whatever their status may be. Be patient as you speak to the patient. For those who cannot speak English, converse in a local language the patient can understand. Before parting, please ask if the patient has any questions over their illness. This sounds funny, but I can assure you, a lot of elderly patients, they are scared to ask. So unless you put it to them, Mama, have you got any questions? Oh, you'll be the darling of the patient. But Dr. She opens up to you to tell you the truth now. So before parting, ask the patient if the patient has any questions over their illness. And as they go, please thank the patient for their patience as they leave you. Coming to testing the patient now, this is an eye clinic. We suppose we are assuming they are coming for vision for an eye problem. The first thing you do is vision testing. It's done usually at 6 meters from the chart the patient has to read. You test one eye reading at a time, and note vision recorded as 6 if they can read all the letters on the chart. I'm sure you've seen the charts, 636, 624, 612, all those. That's the level of the vision where they go, which is understandable by you and your fellow clinicians. After you've recorded, the patient will sit on the slit lamp. Some more coming in.
Questions.
There are questions. Okay,
So I don't know
questions.
if we can take them now.
Yes, why not?
Not clear on aggravating factors. Kindly explain.
Aggravating factors are things which make the disease worse. Those are the aggravating factors. You've got your headache. Elderly mothers will tell you, yeah, uyu muntu mkwai nganaye vati nsende kofi otume nshi ntapa menshi yani shirwa shupa wachilamo. It means carrying of heavy loads on the head worsens the situation. So conditions or situations which worsen heart disease are the aggravating factors you want to know. Is that clear, ladies and gentlemen? Next year.
Okay. Things that causes the symptoms. Oh, wow, that lead to the symptom. Okay. I think that was just an answer someone was trying
to answer. That makes the symptoms worse.
Uh-huh.
And the relieving factors, something which helps.
Uh-huh.
A patient who has been with the disease for some time, they can notice that when I do this, for example, you've got pain in the legs. Obviously, if you walk too much, you will find that by the time it's evening, it's getting worse. You need more Panadol to drink. And if you just rest at, most of the day, you're just sitting room now, no job, all the food is just coming at leisure, you find, no, I'm feeling much better. That's what happens, even if there are people avoiding work to do. Mm-hmm. So once we've done we've got the history, we now go into the examination. We've examined the vision. The next stage is the patient has to come on the slit lamp now. where you examine the pupils. Examine each pupil for direct pupil reaction. You shine a torch directly in the right eye and see the reaction of the right pupil. Each pupil will constrict to light if the pupil is normal, isn't it? You shine a torch there, the pupil should be able to constrict. That's the normal pupillary reaction to light. Examine the pupils by swinging the light from one eye to the other and back. What is called swinging light test. Note, both pupils will constrict normally if the pupils are normal. So from the right to the left, if you are shining on the right will constrict. You go to the left will constrict. You go back to the right. If these pupils are okay, they are normally normal, they will constrict. But you will find a situation where while you are swinging this light from right to left to right to left, at some stage you find you swing it to this pupil. Instead of constricting, now it starts to dilate. Both pupils will constrict normally if the pupils are normal. One pupil will dilate if the pupil innervation is not well, the relative afferent pupillary defect. That's what is referred to as RAPD, relative afferent pupillary defect. Why is it afferent? It's the taking in is afferent. Taking out is efferent. So this is an afferent pupillary relative. It's not a complete. So when you are swinging, it means in this eye, the fibers, there is a partial, partially not correct. They are partially they're destroyed or not functioning well. That's why it's a relative. An absolute defect will not react to light. So let's be very clear. As we are swinging, RAPD. What is RAPD? It's a relative afferent. Afferent as the light is being shown there. Efferent is it? When you are taking out like that.
Questions?
A question? Yes, why not?
Okay. How we can proceed?
There's no question now. Okay, no question. Okay, no problem. We proceed. We proceed. Means everyone is happy. I'm also happy. Why not? Examine each pupil for direct pupil reaction. A torch in the right, see that it's constricting. When you remove, it remains dilating. A torch into the left, like that. Each pupil will constrict to light. What is this time? We are back. Supposed to start 6. Yeah. Each pupil will constrict to light if the pupil is normal. Okay. It's the same slide, isn't it?
Question.
Yeah, what's the question?
And what happens in the case of AAPD?
RAPD, not AA. Relative afferent pupillary defect, RAPD.
Good morning, Doc.
Good morning.
Yes, I mean in the case of absolute afferent pupillary defect.
Okay, absolute defect.
Yes.
When you shine a torch there will be no reaction. It's absolute.
In both eyes.
In both eyes, if both are completely blind, it means we are saying all of them are completely blind with non-functional optic nerves.
Okay. Thank you, Doc.
Thanks. But if it's one eye, it means there will be a reaction in the normal eye. When you go to the other eye, which is the dysfunctional, no reaction. The pupil doesn't constrict. Normally, you will find widely dilated, but they can't constrict. But before, let me warn you, before you say this is an absolute afferent pupillary defect, make sure you have seen that the pupil is not stuck on the lens. The failure to constrict is not due to the sticking of the iris on the lens. Long-standing severe anterior uveitis can lead to that, where the pupil completely is stuck on the lens. Obviously, even if you shine, there will be no pupillary reaction because it's stuck. But where it's not stuck and not reacting while you shine there, then that's an absolute afferent pupillary defect.
Oh,
Okay?
thank you, Doc.
Thank you very much. What is why is it changing? Okay. Once you do the pupils, please let's go now to the examination of the lid margins. Others would start with lid margins before going inward. There are some personal preferences like that. So you can either start with lid margins, then you go on the cornea, then you go on the pupil. From outside, you are going slowly to examine the eye. So from the pupil margins, this is what you see, lid margins and conjunctiva. Signs are variable depending on the underlying condition. If there is lid edema, obviously you will see that the lids are a bit swollen. Conjunctival inflammation, the conjunctiva is inflamed, especially if the conjunctiva is inflamed, more so in the fornix. So if you retract the lower lid, you will see that the fornix, you know, is more inflamed, because if this patient, for example, has got infection, bacterial conjunctivitis, it is more pronounced in the fornix. If the inflammation is arising because of some disease on the cornea, you find that the inflammation of the conjunctiva is more perilimbo. So if you have inflammation perilimbo, know that the disease process must be on the cornea. Either trauma or something went on, chemical splash, trauma, like that. Or a punch, you people like fighting. This is also accompanied with a conjunctival edema. In most inflammatory conditions, this is also an accompanying feature. Look at the conjunctiva for follicles, especially in cases of trachoma. There will be obvious follicles. So this inflammation accompanied by follicles leads you comfortably to this diagnosis of trachoma. If you are saying it's trachoma, okay, there's inflammation, not even one or two follicles on the conjunctiva, you are most likely wrong. Trachoma genuinely must have some follicles.
4 and above. 5 and above.
Is this the last? Let's look at the cornea, examination of the cornea. Cornea is normally transparent. You are able to see the pupil by just looking through the cornea. One is able to see the iris and most of the anterior chamber. With a slit lamp, check the presence of blood cells or clots in the anterior chamber. Check the presence of inflammatory cells in the anterior chamber. And check the pupil shape and pupillary reaction. Because there is inflammation in the anterior chamber, part of the iris margin may be stuck on the lens. You have to start from outside, pupil margin, you go to the conjunctiva, especially the conjunctiva fornix, you go on the conjunctiva, the bulbar conjunctiva, the conjunctiva covering the eyeball, and look at the limbus. If the inflammation is predominantly perilimbo, you are probably dealing with a problem of the cornea. That's what gives you the perilimbo inflammation. Trauma on the cornea, any scratch on the cornea, you find patients who present that way. The cornea may be clear or opaque where the injury went through, and they will have this perilimbo. If it's generalized inflammation, you're going to have it, especially due to bacteria, you are going to have it more prominent in the fornix. Even the pars cells will be there. But the way you go is you start with lid margins, you go to conjunctiva, you retract the lid down to see the palpebral conjunctiva, then you go in the fornix, then you look at the bulbar conjunctiva and look at the perilimbo section. That's when you go into the cornea, see that is clear. You are able clearly to see the anterior chamber. In the anterior chamber, you're looking for inflammatory cells, which you should be able to see. If the inflammation has been standing for a long time, those inflammatory cells have settled inferiorly within the anterior chamber, what you popularly refer to as hypopion. The pupil may still be reacting, or if there's a severe inflammation, part of the pupil stuck on the anterior surface of the lens. Those are signs you see as you are going in. Any problems, ladies and gentlemen? Or I proceed. The lawyers say, I beg to proceed. Examination of the lens. Lens is examined with a dilated pupil so that one can see a large part of the lens. If the pupil is not dilated, it means only that central bit which you can see through the pupil. But it's preferred, if you really want to see, you dilate the pupil, then you can see a bigger portion, because your slit lamp cannot go through the iris. It goes through the pupil where there is no iris. So if you want to see a bigger portion of the lens, you dilate. Short-acting dilating drops can work for a day or two, and the patient will go back to normal. As long as you warn them that vision will be slightly blurred because of the medication I've used, but it should be okay. If you don't warn them, they will think now, oh, this doctor, look, now my eyes, I was even seeing a bit, now I can't even see properly. So let's tell the patients what they are getting. Vitreous examination. Vitreous, this is a clear medium in the posterior chamber of the lens. Vitreous is normally a clear medium, and one can see through the vitreous up to the retina. Presence of hemorrhage or any other particles within the vitreous is not normal. Vitreous is a clear gel. When you dilate the pupil, you are doing your fundoscopy, you should be able to see the retina. You are able to see the retina because you are able to pass through the vitreous gel. You are able to see through that. So any opacities, any vitreous is abnormal. Otherwise, vitreous is supposed to be completely clear. Okay, ladies and gentlemen. Examination of the retina better done with a dilated eye. No, mistake. It's pupil, not retina. You cannot dilate a retina. Yeah, that's better. Dilated pupil. If you want to see the retina, please, you have to dilate the pupil and tell the patient, for a day or so, the pupil, your vision may come down. It's because of the medicine I've put in for me to be able to see the back of the eye. Then the patient will be at ease when they go home. But no, you warned them. Some questions? No. If you don't warn them, yeah, no, the doctor is so down. I'm even blind today. I was seeing a bit. Now I can't even see anything. There's nothing more devastating than losing your sight. There we are. No, not this one. Let's go down, vitreous. Yes, here. I was saying examination of the retina is better done with a dilated pupil, and it's done with a direct ophthalmoscope or on the slit lamp with a fundus lens, 90D or 78D. It's common practice in ophthalmology to have your own either a 90D or 78D. Because sometimes these things are not available there. The iris has to be well dilated for you to have a clear view of the retina with these lenses. And you do it in conjunction with a slit lamp. The slit lamp rays pass through the lens. They are able to show you the retina completely clear and nice. Look at the optic disc. The optic disc is the point at which the retinal fibers from the retinal rods and cones, the rods and cones are the sensory organs, isn't it? In the retina. Those fibers coming from the rods and cones come out of the eyeball to form the optic nerves. That point at which they come out, that's the optic disc. That point at which those fibers come out of the eyeball, that's the optic disc. And one of the important factors you have to look at is whether the optic disc, there is capping of the disc or not. Capping of the disc is suggestive of raised intraocular pressure. And therefore, once you notice capping of the disc, intraocular pressure should be checked if you didn't check initially. And that diagnosis will tell you now is glaucoma. Some questions? No. Ladies and gentlemen, any questions today? Everyone is quiet. They say quiet means what? Consent, or happy. They say quiet means happiness or consent.
What do you mean when you say capping of the disc?
It's like a cap. At the disc, it is protruding because of the pressure within the eyeball. It's protruding outward. There's a cap. If you've seen a cap, there's a space where you go deep inside. So at the disc, that cap forms like the cup you and me use to drink our nice tea. So capping is that protruding outward because of high pressure within the eyeball. They refer to it as capping. And there will be a cap, there will be a normal rim outside, exactly like a cup which you use for water, with a rim inside. And the rim and the cap are all white, sort of. It's part of the optic disc. The larger the cap, it means it has been there for some time and the pressure is higher. Well, initially it starts as a small cap. With time, it enlarges into a big cap. And this is due to pressure bulging outward. And the damage of the nerve fibers which are coming out. Capping will normally go with damage to the nerve fibers coming out. And damage to the nerve fibers coming out means your visual field, you are going to have defects of the visual field. Raised high intraocular pressure, defects of the field, and when you look through, you see this capping like a cup. The fibers go like into a cup, then they are getting out.